Question 1. A 60-year-old male patient with a history of hypertension presents with shortness of breath, chest pain, and palpitations. His vital signs include a blood pressure of 169 mmHg, heart rate of 120 bpm, respiratory rate of 22 breaths per minute, and oxygen saturation of 92%. An X shows an RORS complex with a rate of 150 bpm. Chest X-ray shows mild pulmonary congestion. Based on these findings, what is the most likely diagnosis? A. Atrial fibrillation. B. Acute myocardial infarction. C. Atrial flutter. D. Pulmonary embolism. Answer: C. Atrial flutter. Explanation: atrial flutter is characterized by a rapid atrial rate, typically 240,400 bpm, with a sawtooth pattern on neck, often leading to symptoms such as shortness of breath, palpitations, and chest pain. This patient's ECWID, RORS complex, and the rate of 150 bpm is most consistent with atrial flutter, a common arrhythmia seen in patients with underlying disease, particularly hypertension. While atrial fibrillation can present with similar symptoms, the ECG finding of a regular rhythm with a characteristic sawtooth pattern is more indicative of atrial flutter. Acute myocardial infarction and pulmonary embolism, typically present with different clinical and diagnostic features, including elevations or evidence of a clot on imaging, respectively. Question 2. A 10-year-old female patient presents with a 2-week history of cough, fever, and difficulty breathing. She has a history of asthma, and her oxygen saturation is measured at 89%. Physical examination reveals wheezing on auscultation, and her chest X-ray shows bilateral infiltrates. Which of the following is the most appropriate treatment for this patient? A. Oral antibiotics and inhaled corticosteroids. B. Intravenous fluids and corticosteroids. C. Nebulized bronchodilators and systemic steroids. D. Oral antivirals and supportive care. Answer: C. Nebulized bronchodilators and systemic steroids. Explanation: this patient is presenting with signs of an acute exacerbation of asthma, likely triggered by a viral or bacterial infection. Given the fever and respiratory symptoms, nebulized bronchodilators such as albuterol are the first-line treatment to relieve bronchospasm and improve airflow. Systemic steroids are necessary to reduce inflammation in the airways and help manage the episode. While antibiotics may be considered if a bacterial infection is suspected, the primary focus here is on managing asthma exacerbation, not treating a bacterial infection outright. Oral antivirals and supportive care are not appropriate in this case, as the clinical presentation and X-ray findings are more suggestive of asthma exacerbation rather than a viral pneumonia. Question 3, scenario-based. Mr. Johnson, a 45-year-old male with a history of diabetes and hypertension, presents to your clinic complaining of sudden onset left-sided weakness and difficulty speaking. His symptoms began approximately 2 hours ago. Upon assessment, he is unable to move his left arm and leg, and his speech is slurred. AK of the head is ordered, and no acute hemorrhage is noted. Given the time frame of symptom onset, what should be your next step in management? A. Administer tissue plasminogen activator, TPA. B. Initiate anticoagulation therapy. C. Admit for observation and repeat imaging in 24 hours. D. Start an intravenous antibiotic regimen. Answer A. Administer tissue plasminogen activator, TPA. Explanation: Mr. Johnson's symptoms are highly indicative of an ischemic stroke given the sudden onset of neurological deficits, hemiparesis, and aphasia. The absence of hemorrhage on the CT scan, along with the timing of symptom onset within the last 3 hours, makes him a candidate for tissue plasminogen activator, EPA, a thrombolytic agent that can help dissolve causing the ischemic event. This treatment is most effective when administered within a 3 to 4.5 hour window from symptom onset. Anticoagulation therapy is not recommended immediately in the acute phase of ischemic stroke, especially in the setting of a potential thrombotic cause. Observation and delaying imaging would not be appropriate, as early intervention is crucial. Antibiotics are not indicated, as this is not an infectious process. Question 4. A 58-year-old male with a history of coronary artery disease and type 2 diabetes presents to your clinic for a routine follow-up. He reports feeling fatigued for the past few weeks and mentions occasional dizziness when standing up quickly. On physical examination, his blood pressure is 130/85 mmHg, heart rate is 75 bpm, and respiratory rate is 18 breaths per minute. His laboratory results show that ATIC of 8.5% and A lipid profile reveals an elevated LDL cholesterol of 106 mdl. Given these findings, which of the following is the most appropriate intervention to address his cardiovascular risk? A. Initiate a statin for hyperlipidemia. B. Prescribe a beta blocker for fatigue. C. Increase insulin dosage for diabetes management. D. Recommend lifestyle changes only. Answer 8. Initiate a statin for hyperlipidemia. Explanation: this patient has multiple risk factors for cardiovascular disease, including a history of coronary artery disease, type 2 diabetes, and elevated LDL cholesterol. Statins are first-line therapy for reducing LDL cholesterol in high-risk patients like this one, significantly lowering the risk of future cardiovascular events, while managing diabetes and encourage lifestyle changes, such as dietary modifications and increased physical activity, are important. Statins provide a more immediate and substantial benefit in reducing cardiovascular risk. Beta blockers, while useful in managing heart failure or arrhythmias, are not appropriate for fatigue in the absence of these conditions, and increasing insulin dosage is not warranted based on his current HbAC. Question 5. A 45-year-old female presents with complaints of abdominal pain, bloating, and diarrhea for the past 6 months. She also reports feeling fatigued and having difficulty concentrating at work. Her symptoms are often triggered by certain foods, and she has noticed that stress exacerbates her condition. Physical examination is unremarkable. Laboratory tests, including CBC and metabolic panel, are normal. A colonoscopy performed, and the results show no structural abnormalities. Given these findings, what is the most likely diagnosis? A. Irritable bowel syndrome (IBS). B. Celiac disease. C. Inflammatory bowel disease (IBD). D. Gastroesophageal reflux disease. Answer A. Irritable bowel syndrome (IBS). Explanation: this patient presents with typical symptoms of IBS, which include abdominal pain, bloating, and changes in bowel habits such as diarrhea. IBS is a functional gastrointestinal disorder, meaning it is not caused by structural abnormalities, but rather by a dysregulation of gut motility and sensitivity. The absence of abnormal laboratory results, unremarkable physical examination, and normal colonoscopy all point to IBS. Celiac disease (IBD) and GERD would typically present with different clinical features and abnormal test results. Celiac disease would show elevated transglutaminase antibodies. IBD would present with visible inflammation on colonoscopy, and GERD would primarily cause heartburn and regurgitation. Question 6. A 72-year-old male presents to the emergency department with severe chest pain radiating to his left arm and shortness of breath. He has a history of hypertension, hyperlipidemia, and smoking. On examination, his blood pressure is 159 mmHg, heart rate is 105 bpm, and respiratory rate is 22 breaths per minute, an exhaustant segment elevation neuromentomendarf. Given this presentation, what is the most appropriate first-line management for this patient? A. Administer nitroglycerin and aspirin. B. Initiate heparin infusion. C. Perform immediate coronary angiography. D. Provide pain management with opioids. Answer A. Administer nitroglycerin and aspirin. Explanation: this patient is presenting with symptoms consistent with an acute myocardial infarction, particularly an inferior wall STEMI segment elevation myocardial infarction, as evidenced by the ECG findings. The first-line management for STEMI includes administration of aspirin to inhibit platelet aggregation and reduce clot formation, and nitroglycerin to relieve pain and myocardial oxygen demand. Heparin and opioids may be considered as part of subsequent management, but are not the first-line interventions. Immediate coronary angiography is also an option, but typically follows initial stabilization with aspirin and nitroglycerin. Pain management with opioids may be given for symptom relief, but is secondary to the management of the underlying myocardial ischemia. Question 7. A 28-year-old woman presents with complaints of fatigue, frequent urination, and increased thirst for the past 3 months. She has also noticed blurred vision and a 10-pound weight loss despite normal appetite. On physical examination, her blood pressure is 138 mmHg, heart rate is 88 EPM, and respiratory rate is 16 breaths per minute. Her laboratory results show a fasting blood glucose of 230 mdl and an HbAC of 9%. What is the most likely diagnosis and what is the first-line treatment for this condition? A. Type 1 diabetes mellitus. Insulin therapy. B. Type 2 diabetes mellitus. Oral antihyperglycemics. C. Gestational diabetes insulin therapy. D. Diabetes insipidus or desmopressin. Answer: B. Type 2 diabetes mellitus oral antihypoglycemics. Explanation: this patient presents with classic symptoms of diabetes mellitus, fatigue, polyuria, polydipsia, weight loss, and has laboratory findings indicative of uncontrolled blood glucose fasting glucose of 200 mgl and a H-back of 9%. Given her age and the fact that she is not pregnant, the most likely diagnosis is type 2 diabetes mellitus. The first-line treatment for type 2 diabetes includes lifestyle modifications, diet and exercise, and oral antihypoglycemics, such as metformin, which improves insulin sensitivity and reduces hepatic glucose production. Type 1 diabetes would typically present earlier in life and is treated primarily with insulin. Gestational diabetes occurs during pregnancy, and diabetes insipidus is characterized by poly due to impaired renal water reabsorption, not elevated blood glucose. Question 8. A 65-year-old male with a history of chronic obstructive pulmonary disease (COPD) presents with increased dyspnea, a productive cough, and fever. He is febrile. An auscultation reveals decreased breath sounds with crackles in the lower lung fields. A chest X-ray shows consolidation in the right lower lobe. His sputum culture grows Streptococcus pneumoniae. Given these findings, what is the most appropriate antibiotic therapy for the patient? A. Azithromycin. B. Levofloxacin. C. Amoxicillin clavulanate. D. Ceftriaxone. Answer: C. Amoxicillin clavulanate. Explanation: this patient is presenting with signs and symptoms of a community-acquired pneumonia (CAP), likely due to Streptococcus pneumoniae, a common pathogen in such infections. In patients with COPD, the treatment of CAP often includes a broader spectrum antibiotic to cover both typical and atypical pathogens. Amoxicillin clavulanate is a recommended first-line treatment as it covers Streptococcus pneumoniae and other respiratory pathogens, including anaerobes. Azithromycin and levofloxacin could also be effective against atypical organisms, but they are less targeted against Streptococcus pneumoniae. Ceftriaxone is often used in more severe cases of pneumonia or when intravenous therapy is needed, but is less ideal for outpatient management. Question 9. A 35-year-old female presents with recurrent headaches, visual disturbances, and a recent episode of nausea and vomiting. On examination, she has elevated blood pressure 106/95 mmHg and bilateral papilledema. On fundoscopic examination, OK of the head reveals no structural abnormalities, but her lumbar puncture shows elevated opening pressure and normal cerebrospinal fluid (CSF) analysis. Given this patient's presentation, what is the most likely diagnosis and what is the next step in management? A. Brain tumor, MRI of the brain. B. Idiopathic intracranial hypertension, acetazolamide. C. Migraines, abortive therapy with triptans. D. Preeclampsia, delivery of the baby. Answer: B. Idiopathic intracranial hypertension. Acetazolamide. Explanation: this patient presents with symptoms of increased intracranial pressure, headaches, nausea, vomiting, and papilledema, and her lumbar puncture shows elevated opening pressure with normal CSF analysis, which is suggestive of idiopathic intracranial hypertension, also known as pseudotumor cerebri. The next step in management is the initiation of acetazolamide, a carbonic anhydrase inhibitor that reduces cerebrospinal fluid production and alleviates symptoms of increased intracranial pressure. A brain tumor is unlikely given the normal CT scan, and migraines typically do not cause papilledema. Preeclampsia would be an unlikely diagnosis in this patient as she has no signs of pregnancy. Question 10. A 40-year-old male with a history of chronic kidney disease (CKD) and hypertension presents with sudden onset lower back pain, hematuria, and flank tenderness. He denies any trauma. Laboratory results show an elevated creatinine level 2.5 mdl and urine dipstick positive for blood, but no red blood cell casts. A non-contrast CT scan of the abdomen reveals bilateral renal stones. What is the appropriate management for this patient's condition? A. Surgical removal of the stones. B. Initiate pain management with NSAIDs. C. Perform a percutaneous nephrolithotomy. D. Provide conservative management with hydration and alpha blockers. Answer: D. Provide conservative management with hydration and alpha blockers. Explanation: this patient has bilateral renal stones and presents with typical symptoms of nephrolithiasis, hematuria, flank pain, Given his chronic kidney disease and elevated creatinine level, invasive procedures like surgical removal or percutaneous nephrolithotomy should be reserved for cases of large stones obstruction or failure of conservative management. Most patients with renal stones that are small to moderate in size and causing mild symptoms, the first-line treatment is conservative management, which includes hydration to help pass the stones and alpha blockers, such as tamsulosin, to relax the ureter and facilitate stone passage. NSAIDs should be avoided in patients with chronic kidney disease due to their potential nephrotoxic effects. Question 11. A 32-year-old female with a history of polycystic ovary syndrome (PCOS) presents for an annual checkup. She reports irregular menstrual cycles, excessive hair growth on her chin, and difficulty losing weight despite dieting and exercising. Physical examination reveals mild hirsutism and an enlarged, palpable ovary on the right. Her serum testosterone level is mildly elevated. Which of the following is the appropriate first-line treatment for this patient's symptoms? A. Oral contraceptives. B. Metformin. C. Spironolactone. D. Clomiphene citrate. Answer A. Oral contraceptives. Explanation. This patient presents with symptoms consistent with polycystic ovary syndrome (PCOS), including irregular menstruation, hirsutism, and elevated testosterone levels. Oral contraceptives are first-line therapy for managing the symptoms of PCOS, particularly menstrual irregularity and hirsutism, as they regulate the menstrual cycle and reduce androgen production. Spironolactone is an anti-androgen that may help with hirsutism but is not first-line treatment in this case. Metformin can be used for insulin resistance and weight management in PCOS but is not first line for the symptoms described. Clomiphene citrate is used for infertility in PCOS but is not indicated for managing the symptoms in this case. Question 12. A 58-year-old male with a history of coronary artery disease (CAD) and hypertension presents to the emergency department with severe chest pain radiating to his left arm, shortness of breath, and nausea. His blood pressure is 106 to 90 mm Hg, heart rate is 102 beats per minute, and oxygen saturation is 95% on room air. An excrescent segment elevation in the end leads. What is the most appropriate next step in management? A. Administer oral aspirin and observe. B. Start intravenous nitroglycerin and morphine. C. Administer thrombolytics and prepare for urgent coronary angiography. D. Initiate oral beta blocker therapy. Answer. C. Administer thrombolytics and prepare for urgent coronary angiography. Explanation. This patient is presenting with acute segment elevation myocardial infarction, STEMI indicated by chest pain, findings of elevation, and associated risk factors such as CAD and hypertension. The most appropriate next step in management for STEMI is reperfusion therapy, either through thrombolytics if angiography is not immediately available, or urgent coronary angiography for percutaneous coronary intervention (ECI). Oral aspirin and observation are not sufficient for STEMI management. Nitroglycerin and morphine can be used for pain relief and to reduce myocardial oxygen demand, but should be administered after the initial treatment with thrombolytics or PCI. Beta blockers are not given in the acute phase of STEMI until reperfusion therapy is initiated. Question 13 scenario. Mr. Roberts is a 47-year-old male with a 20-year history of type 2 diabetes mellitus. He presents with increasing fatigue, increased thirst, and blurred vision over the past week. His blood glucose level is 300 FOF/DL and his HbAC is 10.2%. He is currently on metformin, but his blood sugar control has been suboptimal. He denies any history of ketoacidosis (DKA) or hyperosmolar hypoglycemic state (HS), but appears confused. You are concerned that he may be at risk for a hyperosmolar state. What is the most appropriate next step in his management? A. Administer intravenous insulin and fluids immediately. B. Start oral glipizide and monitor glucose levels. C. Admit to the IQ for intravenous fluids and monitoring. D. Provide education on diet and exercise and schedule a follow-up appointment. Answer A. Administer intravenous insulin and fluids immediately. Explanation. Mr. Roberts is presenting with symptoms of uncontrolled diabetes, including hypoglycemia, fatigue, and blurred vision. His elevated HbAC and confusion also raise concern for hyperosmolar hypoglycemic state, a potentially life-threatening complication of type 2 diabetes. The first-line management of HS involves aggressive intravenous and insulin therapy to reduce glucose levels and correct electrolyte imbalances. All medications are not appropriate in this acute situation, and while monitoring may be necessary, immediate treatment with Romanuids and insulin is critical. The ICU admission may be considered depending on the severity, but initial stabilization with these interventions is the first priority. Question 14. A 50-year-old female with a history of hypertension, hyperlipidemia, and smoking presents with progressive lower extremity swelling, fatigue, and shortness of breath. She has a two-pack year smoking history and works as a teacher. Physical examination reveals bilateral ankle edema, jugular venous distension, and a loud air heart sound. A chest X-ray shows cardiomegaly, and an echocardiogram reveals left ventricular hypertrophy. With a decreased ejection fraction, what is the most likely diagnosis for this patient? A. Congestive heart failure with preserved ejection fraction. B. Acute myocardial infarction. C. Chronic obstructive pulmonary disease exacerbation. D. Congestive heart failure with reduced ejection fraction. Answer: D. Congestive heart failure with reduced ejection fraction. Explanation: this patient presents with symptoms and physical exam findings consistent with congestive heart failure, CHF, including lower extremity edema, shortness of breath, jugular venous distension, and a loud air heart sound. The decreased ejection fraction on echocardiogram further supports the diagnosis of CHF with reduced ejection fraction. HFrEF risk such as hypertension, hyperlipidemia, and smoking increase the risk for heart failure, especially HFrEF, which is characterized by impaired myocardial contraction and reduced cardiac output. CHF with preserved ejection fraction, HFpEF, would present with a normal or near normal ejection fraction. An acute myocardial infarction or COPT exacerbation would present with different clinical features. Question 15. A 68-year-old male with a history of chronic obstructive pulmonary disease, COPT, presents with worsening shortness of breath, wheezing, and productive cough. He reports increased sputum production and a change in the color of the sputum. On examination, he has decreased breath, sounds bilaterally, wheezing, and a prolonged expiratory phase. His oxygen saturation is 88% on room air. What is the most appropriate next step in the management of this patient? A. Administer a systemic corticosteroid and antibiotics. B. Initiate intravenous diuretics. C. Start non-invasive positive pressure ventilation NIP. D. Perform a chest CT scan. Answer A. Administer systemic corticosteroid and antibiotics. Explanation: this patient with a history of COPT is presenting with an acute exacerbation as evidenced by worsening shortness of breath, increased sputum production, and a change in sputum color. The most appropriate next step in management is the initiation of systemic corticosteroids and antibiotics, as these are key components of the treatment for COPT exacerbations when there is evidence of infection, such as purulent sputum. Non-invasive positive pressure ventilation (NIP) may be indicated if the patient becomes more hypoxic or experiences respiratory failure. Diuretics and chest CT are not appropriate for managing acute COPT exacerbations. Question 16. A 34-year-old female with a history of migraines presents with a severe headache that began suddenly during exercise. She describes the headache as the worst she has ever had and also has associated nausea and photophobia. On examination, she has a positive Brzezinski sign and a fever of 100 Tudig. CT scan of the head is normal. What is the most appropriate next step in management? A. Initiate migraine treatment with triptans. B. Perform lumbar puncture to evaluate for meningitis. C. Start oral acetaminophen and observe. D. Administer Romanuids and wait for further symptoms. Answer B. Perform a lumbar puncture to evaluate for meningitis. Explanation: this patient presents with an acute severe headache that is described as the worst headache of her life, along with photophobia, nausea, and a fever, which are concerning for meningitis, particularly bacterial meningitis. A normal CT scan does not exclude this diagnosis, and the next step in management should be a lumbar puncture to assess cerebrospinal fluid. CSF for signs of infection. Migraine treatment is not appropriate in the context of a severe atypical headache with neurologic signs. Observation and acetaminophen are not appropriate given the concern for meningitis. Question 17. A 60-year-old male with a history of hypertension and smoking presents with sudden onset severe chest pain radiating to the back and shortness of breath. On examination, he has a blood pressure of 107 to 110 millimeters Hg head, a weak pulse in the right arm. A chest X-ray shows a widened mediastinum. What is the most likely diagnosis? A. Acute myocardial infarction. B. Aortic dissection. C. Pulmonary embolism. D. Esophageal rupture. Answer: B. Aortic dissection. Explanation: this patient presents with classic symptoms of an aortic dissection, including sudden onset severe chest pain radiating to the back, hypertension, and a weak pulse in one arm, suggesting differential perfusion. A widened mediastinum on chest X-ray is low, a hallmark of aortic dissection. This condition is a medical emergency and immediate imaging with CT angiography or transesophageal echocardiography is needed for diagnosis. Acute myocardial infarction, pulmonary embolism, and esophageal rupture would present with different clinical findings. Question 18. A 72-year-old female with a history of osteoarthritis presents with severe right knee pain that has progressively worsened over the last few weeks. She reports difficulty walking and a feeling of instability in the knee. Physical examination reveals joint swelling, tenderness, and decreased range of motion. An X-ray shows joint space narrowing, osteophytes, and subchondral sclerosis. What is the most appropriate management for condition? A. Initiate opioid therapy for pain management. B. Recommend a knee brace and physical therapy. C. Begin intra-articular corticosteroid injections. D. Schedule the patient for total knee replacement. Answer: B. Recommend a knee brace and physical therapy. Explanation: this patient presents with typical symptoms and X-ray findings consistent with osteoarthritis OA, including joint space narrowing, osteophytes, and subchondral sclerosis. The first-line treatment for OA includes non-pharmacologic measures such as physical therapy and the use of assistive devices like knee braces. While intra-articular corticosteroid injections can provide short-term pain relief, they are typically used when conservative measures fail. Opioids should generally be avoided due to their addictive potential. Total knee replacement may be necessary in severe cases but is not indicated as an initial treatment. Question 19. A 30-year-old male presents with a sudden, painful, swollen left testicle. He reports that the pain started earlier in the day and has progressively worsened. On examination, the left testicle is enlarged, tender, and elevated. The cremasteric reflex is absent on the left side, and the testicle is not transilluminating. What is the most likely diagnosis? A. Epididymitis. B. Testicular torsion. C. Inguinal hernia. D. Orchitis. Answer: B. Testicular torsion. Explanation: this patient presents with classic signs and symptoms of testicular torsion, including sudden severe testicular pain, swelling, and an absent cremasteric reflex. The absence of the cremasteric reflex is a key sign of testicular torsion, which occurs when the spermatic cord twists, cutting off blood supply to the testicle. This is a surgical emergency that requires prompt diagnosis and intervention, typically torsion or orchiopexy. Epididymitis would more commonly present with gradual pain, often associated with urinary symptoms or a history of infection. An inguinal hernia typically presents with a visible bulge and discomfort, but it would not cause absent cremasteric reflex. Orchitis, and inflammation of the testicle, typically presents with fever and more gradual onset of pain. Question 20. A 45-year-old female presents with a persistent cough for the past 6 weeks, along with unintentional weight loss and night sweats. She reports no significant travel history or exposure to tuberculosis (TB), but she has a history of smoking. Physical examination reveals crackles in the upper lung fields, and a chest X-ray shows a cavitary lesion in the right upper lobe. What is the most likely diagnosis? A. Bronchogenic carcinoma. B. Tuberculosis. C. Community-acquired pneumonia. D. Fungal lung infection. Answer: B. Tuberculosis. Explanation: this patient presents with classic signs and symptoms of tuberculosis (TB), including a persistent cough, weight loss, night sweats, and a cavitary lesion on chest X-ray. Although she reports no significant travel history or known exposure, smoking is a risk factor for TB, especially in individuals with compromised immune systems. Bronchogenic carcinoma is a consideration, but TB should be prioritized due to the cavitary lung lesion, which is a hallmark of TB. Community-acquired pneumonia would present with acute symptoms, including fever and shortness of breath, and would not typically cause a cavitary lesion. Fungal lung infections can also cause cavitary lesions, but would be less likely given the patient's presentation. Question 21. A 28-year-old pregnant female presents for a routine prenatal visit at 28 weeks gestation. She reports experiencing some swelling in her feet and ankles, which has gradually worsened over the past 2 weeks. She denies headaches, visual changes, or abdominal pain. On examination, her blood pressure is 130/80 millimeters Hg and her urine dipstick is negative for protein. What is the most appropriate management for this patient's symptoms? A. Recommend increasing fluid intake and rest. B. Monitor blood pressure and schedule follow-up visit in 2 weeks. C. Perform 24-hour urine collection for protein and creatinine clearance. D. Start antihypertensive therapy to manage symptoms. Answer A. Recommend increasing fluid intake and rest. Explanation. This patient presents with edema in the lower extremities, which is common in the second and third trimesters of pregnancy and may be due to normal physiological changes. The absence of proteinuria, hypertension, and other concerning symptoms such as headache or visual changes suggests that this is uncomplicated edema, often referred to as physiological or benign swelling. The approach is to recommend lifestyle modifications such as increasing fluid intake, elevating the legs, and encouraging rest. Further tests, such as a 24-hour urine collection, are not necessary unless other signs of preeclampsia develop, e.g. high blood pressure or proteinuria. Antihypertensive therapy is not indicated unless blood pressure rises significantly. Question 22. A 25-year-old male presents with a painless lump in his right testicle that has been gradually increasing in size over the past 2 months. He denies any trauma or history of infection. On examination, there is a firm, non-tender mass in the right testicle that does not transilluminate. There is no associated lymphadenopathy. What is the most likely diagnosis? A. Epididymitis. B. Testicular torsion. C. Testicular cancer. D. Hydrocele. Answer. C. Testicular cancer. Explanation. This patient presents with a painless, gradually enlarging testicular mass, which is most suggestive of testicular cancer. Testicular cancer often presents as a firm, non-tender mass that does not transilluminate. While epididymitis and testicular torsion can cause testicular pain and swelling, they would not typically present with a painless mass. A hydrocele, which is a fluid-filled sac around the testicle, is not associated with a firm mass and would transilluminate. Testicular cancer is the most likely diagnosis, and the next step would be to perform scrotal ultrasound to confirm the diagnosis and determine whether a biopsy or orchiectomy is necessary. Question 23. A 67-year-old male with a history of chronic kidney disease, CKD, and hypertension presents with fatigue, nausea, and anorexia. On examination, his blood pressure is 106/90 mm Hg and he has bilateral lower extremity edema. Laboratory results reveal a serum creatinine of 3.4 EDDL, previous baseline 2.0 EDDL, and a blood urea nitrogen bun of 4 MDDL. What is the most appropriate next step in management? A. Increase the dose of antihypertensive medication. B. Start hemodialysis immediately. C. Perform a renal ultrasound to assess for obstruction. D. Increase fluid intake to promote renal function. Answer. C. Perform a renal ultrasound to assess for obstruction. Explanation. This patient with chronic kidney disease, CKD, presents with worsening renal function, as evidenced by an increase in creatinine from baseline and symptoms suggestive of uremia, fatigue, nausea, anorexia. The most appropriate next step is to perform a renal ultrasound to evaluate for potential causes of acute kidney injury, such as obstruction, e.g. from the stone or enlarged prostate. Hemodialysis may be required if the patient's renal function deteriorates further or if he develops severe symptoms of uremia. Increasing antihypertensive medications and fluid intake alone are not sufficient without first evaluating for any underlying cause of his worsening renal function. Question 24. A 70-year-old female with a history of osteoarthritis presents with progressive knee pain and limited mobility despite taking acetaminophen and using topical NSAIDs. X-rays reveal significant joint space narrowing and osteophytes. Given her symptoms and radiographic findings, what is the next step in her management? A. Refer for total knee replacement. B. Initiate a trial of oral corticosteroids. C. Recommend intra-articular corticosteroid injections. D. Schedule for physical therapy. Answer. C. Recommend intra-articular corticosteroid injections. Explanation. This patient presents with osteoarthritis OA, symptoms that are not well controlled with acetaminophen and topical NSAIDs. Intra-articular corticosteroid injections are often used as a next step in managing OA symptoms, particularly for joint inflammation and pain relief. Physical therapy can also be helpful for improving mobility and strengthening the surrounding muscles. Total knee replacement may be considered if conservative measures fail or if the O is severely debilitating. Oral corticosteroids are not typically used for OA management due to the potential for systemic side effects and limited efficacy in this condition. Question 25. A 45-year-old male with a history of heavy alcohol use presents with confusion, tremors, and diaphoresis after abruptly stopping alcohol consumption for the past 24 hours. On examination, he has an elevated heart rate, mild hypertension, and tremors in both hands. His laboratory results show a mild metabolic acidosis with an elevated anion gap. What is the most likely diagnosis? A. Alcoholic liver disease. B. Alcohol withdrawal syndrome. C. Acute pancreatitis. D. Hypoglycemic hyperosmolar. Answer: B. Alcohol withdrawal syndrome. Explanation: this patient with a history of heavy alcohol use and recent cessation of alcohol is presenting with symptoms of alcohol withdrawal syndrome, which includes confusion, tremors, diaphoresis, tachycardia, and hypertension. Alcohol withdrawal can occur within hours to days after cessation and can progress to more severe complications such as delirium tremens. The elevated anion gap may indicate the presence of metabolic acidosis, which can occur in alcohol withdrawal due to the accumulation of acidic metabolites. Alcoholic liver disease, pancreatitis, and HHS are less likely given the acute onset of symptoms related to alcohol cessation. Question 26. A 60-year-old male presents to the emergency department with sudden onset severe chest pain radiating to his back. He describes the pain as tearing and states that it started after lifting a heavy object. On physical examination, his blood pressure is 106/90 mm 8G in the right arm and 130/80 mm 8G in the left arm. There is a difference in pulses between the two arms. What is the most likely diagnosis and what is the next step in management? A. Myocardial infarction. Administer aspirin and start anticoagulation. B. Aortic dissection. Obtain an angiogram or transesophageal echocardiogram. C. Pulmonary embolism. Initiate anticoagulation therapy. D. Peptic ulcer disease. Provide proton pump inhibitors and romanoids. Answer: B. Aortic dissection. Obtain an angiogram or transesophageal echocardiogram. Explanation: this patient presents with classic symptoms of aortic dissection, including sudden onset, severe chest pain that radiates to the back end, a difference in blood pressure and pulses between the arms. The tearing nature of the pain and the physical exam findings suggest the need for immediate imaging to confirm the diagnosis. A angiogram or transesophageal echocardiogram (T) is typically used for diagnosing aortic dissection. Myocardial infarction can also cause chest pain, but the radiation of pain, arm pulse discrepancy, and sudden onset are more indicative of an aortic dissection. Pulmonary embolism (P) can cause chest pain and tachycardia, but would not cause arm pulse differences. Peptic ulcer disease would present with epigastric pain rather than severe radiating chest pain. Question 27. A 50-year-old woman with a history of type 2 diabetes mellitus presents with polyuria, polydipsia, and weight loss. She reports feeling fatigued and has noticed blurred vision over the past few weeks. Her fasting blood glucose is 320 mdl and her HbAC is 11%. Urinalysis shows glucose in the urine, but no ketones. What is the most appropriate next step in management for this patient? A. Initiate insulin therapy. B. Start a sulfonylurea medication. C. Increase her oral metformin dose. D. Refer for bariatric surgery. Answer: A. Initiate insulin therapy. Explanation: this patient is presenting with symptoms of uncontrolled diabetes, including polyuria, polydipsia, weight loss, and blurred vision, along with elevated blood glucose levels and an HbAC of 11%. The absence of ketones in the urine suggests that she is not in diabetic ketoacidosis (DK), but her glucose levels are significantly elevated, indicating poor control. Given the of hypoglycemia, insulin therapy should be initiated to achieve better glycemic control, while sulfonylureas and increased doses of metformin are treatment options for type 2 diabetes. The patient's significantly elevated blood glucose and symptoms suggest that insulin is needed initially to rapidly control her blood glucose. Bariatric surgery may be considered for weight loss in patients with obesity and diabetes, but is not an immediate next step in this case. Question 28. A 45-year-old male with a history of hypertension presents with sudden onset headache, vomiting, and confusion. On examination, he has a Glasgow Coma Scale (GCS) score of 12 and his blood pressure is 200/120 mm Hg. EK of the head reveals a large intraparenchymal hemorrhage in the right parietal lobe. What is the most appropriate next step in management for this patient? A. Administer thrombolytics to dissolve the clot. B. Start antihypertensive therapy to lower the blood pressure. C. Perform a craniotomy to evacuate the hemorrhage. D. Administer corticosteroids to reduce cerebral edema. Answer: B. Start antihypertensive therapy to lower the blood pressure. Explanation: this patient is presenting with acute symptoms of a hypertensive emergency, which includes a high blood pressure of 200 and 120 millimeters Hg and an intraparenchymal hemorrhage on CT scan. In hypertensive emergency, the blood pressure should be lowered gradually to reduce the risk of further hemorrhage or other complications such as ischemic events. Goal is to lower the mean arterial pressure by no more than 25% within the first hour, and then further reduce it to 106 to 100 millimeters Hg over the next 6 hours. Thrombolytics are not indicated in hemorrhagic strokes as they could worsen bleeding. A craniotomy may be needed if the hemorrhage is large and causing significant mass effect, but the immediate step is blood pressure control. Corticosteroids, used in conditions such as brain tumors or edema but are not indicated in hemorrhagic stroke. Question 29. A 22-year-old female presents to the clinic complaining of a painless mass in her breast that has been present for the past few months. On examination, the mass is firm, mobile, and well-defined. The overlying skin is normal, and there is no nipple discharge. Mammography reveals a well-circumscribed hypoechoic lesion. What is the most likely diagnosis, and what is the next step in management? A. Breast carcinoma. Proceed with biopsy. B. Fibroadenoma. Perform a fine needle aspiration. C. Cyst to recommend observation and follow-up. D. Lipoma. No further intervention required. Answer: B. Fibroadenoma. Perform a fine needle aspiration. Explanation: this patient's presentation of firm, mobile, well-defined breast mass with normal skin and no nipple discharge is highly suggestive of fibroadenoma, benign breast tumor common in younger women. Mammography reveals hypoechoic lesion, which is typical of fibroadenoma. Fine needle aspiration (FNA) or core needle biopsy is recommended to confirm the diagnosis and out malignancy. Breast carcinoma would present with more concerning features, such as an irregular, hard mass or skin changes. Cyst would usually present with fluctuation in size or pain and would be confirmed by aspiration or ultrasound. Lipomas are benign fatty tumors but are less common in the breast. Question 30. A 30-year-old male presents with a rash on his hands and feet that began 2 days ago. The rash started as small red spots and has since developed into blisters. He also reports a mild fever and joint pain. On examination, the rash is erythematous and vesicular, and there is tenderness in the joints. His recent medical history includes a cold sore on his lip that cleared up a week ago. What is the most likely diagnosis? A. Hand, foot, and mouth disease. B. Chickenpox. C. Herpetic whitlow. D. Herpes zoster. Answer: A. Hand, foot, and mouth disease. Explanation: this patient's presentation of rash starting on the hands and feet, along with fever and joint pain, is most consistent with hand, foot, and mouth disease, which is caused by coccidiovirus or enterovirus. The rash often starts as small red spots or maculopapular lesions that evolve into vesicles. The history of cold sore suggests previous exposure to the herpes simplex virus, but with localized HSV infection on the hands would present with painful vesicles and no fever. Chickenpox would cause generalized pruritic rash with more vesicles and scabs, but it typically affects the trunk and face, not just the hands and feet. Herpes zoster, shingles, usually presents with dermatomal vesicular rash and is unlikely in this young, healthy patient.